Good morning, India. Good morning, India. This is the second case. I am Dr. Ahn from Asan Medical Center. This is a 65-year-old gentleman complaining of effort chest pain for several months. Treatment test showed the positive recovery phase. So we performed the coronary angiogram. So let's just see his coronary angiogram. His coronary risk factor is only the hyperlipidemia. This is the first shot of his coronary angiogram. Very tight stenosis of left main and maybe involved this left main bifurcation. Next. Yeah, this is a view. So we discussed with the surgeons, but he preferred, and then this disease only focused on the left main. So we decided to perform the left main stenting. Next, this is spider view. Left main ostium and involved shaft lesion, and angiographic may be involved in the distal bifurcation. By angiographically, the left circumflex ostium status is not definite, so we need further evaluation by using IVUS. And next, this is cranial view, basically very diffuse LAD disease, but we think above the second diagonal branch, there is angiographically the good landing zone for distal stent edge. Next. So we insert two wire, LAD BMW intermediate wire, and for circumflex BMW intermediate wire. And then we evaluated IVUS first to determine the left circumflex ostial status. Let's see the...
Okay. Did you do the IVUS both?
Yes,
both
okay,
why not? Would you show us the IVUS? Yeah. There's a run from LAD?
This is a circumflex
okay, circumflex
run.
first, right?
Yes.
Why not? Would you show that? Okay.
Distal,
from the distal?
From the distal.
Size-wise, it's a very big one, right?
OM distal부터 보여주세요. Yeah, start.
3O?
Yes.
Minimal plaque has some superficial calcium, and 3025 small branches from 5 o'clock. Superficial calcium still. However, medial is 3O, more than that, it's big vessel, and eccentric plaque, smaller one, getting bigger vessel, getting bigger. Okay, small branches in 6 o'clock, lots of plaque. All right, 3O, stop it. Okay, that is just 1 or 2 backward. Okay, perfect, that one. That is, meeting areas from circumflex ostium and LAD. Another wire is in the 6:30, 6 o'clock is LAD wire. You can clearly see that, white one. The meaning is circumflex ostial part, reference vessel diameter is almost 3O, more than that.
Yes, right.
And then there are lots of plaque. So whatever, functional significance would be, anyway, there are some visible, a plaque on circumflex. And, okay, would you show us, vessel size is 3O? Yeah. Okay, go ahead. So there is, okay, LAD coming in from the 6 o'clock. This is the main disease. Size-wise, almost 4O. Lots of plaque, it's mottling density. They are clearly, related with some polluted plaque over there. Ostial part is eccentric plaque was superficial calcium. Right. Would you show us again for the LAD run from the main?
Next. So for the safety concern, we performed the balloon angioplasty for the left main first using 2.5 20 millimeter balloon. And then we performed the IVUS evaluation from LAD to left main.
All right.
Let's see the left main to LAD to left main.
You have already done 2.5 balloon, right?
Yes.
The reason why there are lots of plaque as the main. Okay, 3O, less than 3O.
Yeah.
Is that after the diagonal branches? That one? Okay.
Yes.
So getting bigger, 3O vessel, diffuse disease. We have a lot of information from the IVUS. The reason why it's almost the main bifurcation disease interventions we prefer IVUS. Okay, big diagonal branches coming in from the 1 o'clock. There's big vessels, LED. Oh, some ruptures here, right? Stop. Oh, but could you see that? 1 or 2 back. Okay, that one. There's a 6 o'clock, 7 o'clock. There are, very big ruptures. There is, what about the clinical manifestation? Is unstable, bulletable plaque here. Okay, go ahead. And some, organized thrombus from the 6 to 9 o'clock here. And, okay, there's a size-wise almost 3O. Some calcium. It's quite soft plaque. And getting bigger, vessel size, almost 4, 1, 2, 3, 4, more than that. And some, okay, stop. Circumflex, ostium, getting from the 12 o'clock here. They are basically diffuse disease. Okay, go on. All right, there is the main here. Larger plaque, very much, okay, some, small. All right, that is, balloon damage here. So I just see that some, ruptures here at 6 o'clock and osteopathy. Okay, so the issue is actually very diffuse disease. Some silicon disease from the LED to the main, no doubt about that one, right? Ostial part of circumflex. If you look at the angle relations between the LED and circumflex, there are some disease on the circumflex ostial part. Why not? We're gonna try the two-stent, right?
Yes.
Two-stent technique from the beginning,
Yes.
especially for the main disease. Still, we believe stent crossover, simple procedures would be better than the two-stent technique. However, so we have some clear stent cutoff values to make a good clinical outcome. Restenosis rate less than 5%, here are less than 2%. Quite a good clinical outcome using the IVUS guided stent expansion.
Yes, right.
5, 6, 7, 8 millimeter scale.
Yes,
Because
right.
we've discussed a lot about that. And so, this is very complex, right? Yeah. Diffuse disease, however, I don't too much concern. It's just, stent crush for that, right?
Yes.
What do you think? Two-stent technique?
Yes, good.
And for the stent, landing zones for the LED,
Next.
would you show us a previous one?
Next.
What do you think, Dr. Ahn?
Because of limited time, we already put the one stand
where?
at the prox LED. Let's see.
Here? Where?
Next.
Where was it?
Yes.
All right, good. What side?
3023.
3023?
Yes.
Great. So, could you take a
Proxima-
picture here?
Yeah, next. Next. Next.
Okay, good. I like it, right? 3O?
Yeah, 3
Okay, why not? We're gonna use the, actually it's for the circumflex.
3O.
I will take a aerial caudal, shallow caudal. Okay, good, perfect. Aerial. We're gonna separate with, all right, I like this view. And for the focus on the main and LED and circumflex, take a picture here. Okay, more. The size is big, however, the guide is too big to anchoring the one more. Okay, I like it. So, for the LED 3.5, the reason
Yes.
why is we're going to use the 8-French guides, big ones. For the complex angioplasty, we're going to sometimes use the two stents simultaneously. It's still lots of inner, guiders, etc., etc. And so, I want to choose the 3.5 28.
Yes.
Oh, what do I think? This part we have to cover that, or just no? All right, just the 23 or 28.
The circumflex is 18. LED is 23.
Oh, really?
Yeah.
So 23,
Yeah.
18.
Yeah.
I wanna cover in the first, second obtuse marginal, below the second obtuse marginal branches.
Yeah.
I wanna cover that.
Okay. Then
So 18, I think it's too short.
Yeah.
23.
23. Okay.
Okay, 23 and 23.
Okay.
All right, 3.0, for the circumflex and 3.5 for the LED, right?
Yes.
Okay, good. So we have already balloon inflation
Yes.
for the main to maintain,
Circumflex.
stable hemodynamics.
3.0.
So we
Dr. Bach,
Circumflex.
Dr. Bach, can you hear me?
Yep. Yes.
Good to see you. I'm Dr. Ra.
Yes,
Sung
I
Ra
can hear
from
you
Korea
clearly.
University. It's good to see you from India.
Oh,
I'm one of the coaches.
good to see you.
Yeah, good to see you.
All right.
안녕하세요.
All right,
So
great.
you already have done the predilation in the circumflex arterial area. Only the left main predilation. The circumflex.
No.
Test, please.
Test.
Test, please. I think it's quite enough. You have done predilation?
LED.
Okay, LED. We didn't do that.
Okay. So based on the
We
IBS
didn't
finding,
do.
you
And so
decided
CO 28
So based on the IBS finding, you decided to do
Yes.
two-stem strategy.
is quite,
So you are planning to
yes.
do
So
mini crossing.
in any situation, yes, mini crush. That is more easier to perform. All right, test. Everybody can do that. The mini crushes, even in the, if you got some, good concept. Test, please. Okay, circumflex is good, perfect length. And LED-wise is a test, please. Ostium, where is it? Okay, good. The region actually extended to the ostial part of the main. And then if you look at the floor, just only floral, overlapping stent is quite enough from the first stent. Okay, so the reason why is I pulled the LED stent a little bit, and then test, please. I think the circumflex is quite good, right?
Yes.
Okay, why not? Inflate. Circumflex first. It's quite easy. All right, why not? Inflate. Okay, good.
10.
What
Nominal.
10.
3.0.
Plaque itself is not hard ones. It's soft plaque and
Yeah.
some vulnerable, natures, some ruptures. However, so all right. The reason why is we're gonna do a little bit high pressure for that. Okay, why not? 16.
16.
Okay. All right. So why not? The reason why it is quite easy to perform after the stent deployment, we want to pull out, hold the system, right? It's quite easy. Everybody can do that. Test, please. So another main stent from the LED, overlapping stent from the first one, and I pull the stent 1 millimeter further. All right. It's okay?
Yes, okay.
All right, so in order to cover the ostial part of the main test, please. What do you think?
Okay.
It's okay? All right, why not? Inflate. So nominal pressure. 3.5. Okay, inflate further. 16.
16.
What is the last balloon diameter? 3.75. Okay, patient feels chest pain. So we deflate and push the guider and pull the balloon out here, right? Okay. So why not take a picture here first? Okay. Ooh, I like it. Angiographically, I think it's quite perfect, right? And so we're gonna see. Would you show us the distal and main reference vessel diameters? So what size would it be? Distal and main and proximal LED, right? Would you show that, Ivis? So 3.9. What is that? Distal and main?
Yeah, distal and main.
Okay. What about the proximal LED?
자,
That one. Almost 4. Okay. What do you think? 3.5 non-compliance?
Yes.
Okay. Okay.
Right.
3.5.
3.5 non-compliant 20.
20, 15, it's okay. So before, okay, we're gonna try another wire
Yeah.
for the circumflex. Why not, right?
Yes.
So we're gonna do 3-5 non-compliant balloon hyperinflation.
Yes.
It's kind of a part.
Yeah.
Sometimes, proximal optimization, etc. So it's very difficult. So, however, high pressure, bigger balloon inflation, it can, facilitate the second wires across the circumflex ostium. And then finally, Dr. Wan, you're going to do the, high pressure inflation for the circumflex, and then
Final kissing balloon.
final kissing balloon inflation, especially for the mini crushes. We don't doubt about the final kissing balloon inflation is absolutely mandatory. All right, that would be overlapping area.
Yeah.
So you're gonna do nominal. What is nominal? 12.
12.
10 would be okay. The reason why that is big balloon, right? Air mainly. Okay, why not? 2. So we can clearly see it. I want to see that. What's happened? Okay, good, perfect. 10. Some, tapering,
Yeah.
but this balloon. The meaning is absolute maybe stent diameter is balloon. The reference vessel diameter is not too big.
Yeah.
It's up to 3.5. Okay, deflate. And proximal LAD and left main. The vessel size is quite a big one.
Yes.
So negotiate a 3.5. Why not? 12, 14, 16. 3.6? I think it's, And then, you're going to do, high pressure. This is circumflex.
I think we're
Still
running out
high.
of
There
satellite
must be
time.
some overlap. Just a minute.
Yes.
We're running out of satellite time.
All right.
We'll probably
Okay,
got
inflate.
another few minutes. So we'll just be with you till you finish as much as we
Okay.
can.
20. All right. Okay, you're going to
20.
20.
Yes, 20.
Why not? It's further than main. You're going to make a 20 atmosphere, just 3.5 non-compliant balloon. All right, can make a, quite a big, stent area. And then, okay.
PT.
Okay, then I want to take a picture first. I want to just show that. Okay, I like it. Stent area is quite enough, and so you want to try it. We would like to show the previous cases after the deregulating balloon, the stent cross-sectional area, how much it is, and then we want to finish that. And so, Dr. Ahn,
Okay.
you want to do another wire, so
Okay.
for the circumflex ostium and the final kissing balloon inflation. However, if you look at the angiographic findings, I think it's quite enough, right? Perfect stent areas, circumflex, LED, and left main too, right? And so, okay, you're going to proceed that. And so you're going to see that the first case is final.
Yes. Yes, so we rewire the circumflex stent, and then we remaining the final kissing balloon dilatation. Using the for the circumflex stent, I will choose the 2.75 high pressure balloon for circumflex, and for the LAD, I will use the 3.5 non-compliant balloon. Let's just see. Yeah. This is a 2.75. Please give us a compliant balloon, 2.75. 2.75 compliant balloon, U1, please. 2.5 non-compliant, a compliant balloon, LAD 3.5.
So Dr. Han, you did the predilation with a smaller balloon in the circumflex ostial area. 2.0 or 2.5 before?
Yes, for the circumflex opening,
Yes.
yes, the
2.0.
two opening, the 1.0 balloon, and then 2.5 balloon, we already gradually increased the balloon dilatation for the circumflex stent.
But 2.75 with NC balloon could not pass yet.
Yes. So this is for the LAD. Is this new one?
It's not new, I used to use.
Another good option is you can position the in the LED proximal area with the for the left main kissing balloon, then grabbing by the anchor balloon
3.2.
technique, then you can send the circumflex balloon during the anchor balloon.
Yes, thank you for your comment. So I will insert the first LED.
Okay, it will take us some time. However, we can do that in terms of, in any cases, we didn't experience, cannot cross the balloon and cannot cross the wires and side branch concerns. It will take time. So you almost there.
Circumflex.
This is LED and
Yes.
circumflex, and you may know that sequential high pressure inflation on the circumflex ostium and LED, and finally, kissing balloon inflation. That is our, usual strategy for that. Okay. All right, very easy.
Yes.
So
Okay.
why don't you do that, right?
Circumflex. First, 6,
Dr. Ahn, this is a
6,
compliant
8,
balloon, right?
10.
Complex.
This is non-compliant?
Compliant balloon.
Compliant, because
Yes, compliant balloon.
yeah, he could not
Deflation.
deliver the NC balloon yet. So the
10.
saving circumflex ostium is the most important area. So
Deflation.
I also prefer the NC balloon definitely during the kissing
LAD.
balloon class in the circumflex ostium.
12.
We've got 3 more minutes
10,
before we
12,
have to say
14,
goodbye. So
16.
it's been good, so
Deflation.
very good so far,
Okay.
but we only
Yes.
got 3 more minutes. Satellite time.
4, 8.
All right,
No.
almost there.
Okay.
Okay, I think I really,
4, 4,
we enjoyed
8.
the cases, and I hope you all, enjoyed these 2 cases for the main intervention. Because the main issue is actually we prefer arms-guided procedure, right? Before and after the arms-guided, to measure the stent cross-sectional area is most important predictor for late outcome. That is our, message from the 2 cases. And whatever you choose, the 2-stent technique, I don't worry about that. Still, the single stent is good rather than the 2-stent complex stent procedures. However, okay, perfect. I like this one, right? Why not spider view, right?
That's great result. We really enjoyed the 2 cases, and they were very educational. Thanks very much, and
Right.
see you later.
Right. Thank you. Thank you. Okay. This is final?
Yes.
All right. Great result. So, all right.
고생
Very,
많으셨어요.
very honored to participate in this NIC 2016. Okay. Thank you. All right. You're going to see the later.
수고 많으셨습니다.